Jacob's here. We can go ahead and get started. All right, everyone, we'll go ahead and get started. Welcome to Grand Rounds this morning. Welcome to our optometry applicants. My name's Danny Moore. I'm the Residency Program Director, and most of you in the room don't need an introduction here, but this is Mohamed Khodeiry. He was our fellow last year in glaucoma. He is now faculty at University of Louisville, and he's here today. This is our second time trying this. We want to, if possible, have an annual Grand Rounds that we can invite a Louisville faculty member to come do and try to increase our camaraderie there. This is on the heels of our residents being in Louisville last week for the plastics course. And my understanding is they again lost Jeopardy, although it was quite controversial, the question that the faculty member said could have been correct. Is that okay? So there is some bitterness that Mohamed's going to help kind of resolve today. So he's not only a glaucoma faculty member, he also does neuro-ophthalmology and peds. He's trying to do as little bit of those as possible, but that's because he did a neuro-ophthalmology fellowship at Bascom, a peds fellowship at Pittsburgh, and glaucoma here. So he's very, very well trained. He's done many things already in his time there. He's got a new child, and he somehow has enough time to also take on the surgical education curriculum. So he's done that this first year. He's already taught them a lot, and he has a lot to share. Just briefly mentioning it to me a second ago, I think this is going to be a great talk because he says he wants to share some of the mistakes he's made, so he's going to be vulnerable and honest. And the goal is to help you not make those as well. So not only learn from his own mistakes, but allow you to learn as well. And so I think that's a great way to introduce this topic. And thank you so much for being so much, Dr. Moore.
Oh, thanks so much, Dr. Moore, for the introduction. I'm really happy that I'm back because here, a special place. Most of what I'm doing today, I learned here at UK. So as Dr. Moore said, I'm just trying to share some thoughts about how to improve as a surgeon and some of the mistakes and some of the observations that I had in the past few years. I have no financial disclosures to the context of this lecture, and this is my personal opinions and experiences. Obviously, I have my own biases, and I'm wrong sometimes. And there are some VDs, and most of them are from Cataract Coach. So the idea is smart people learn from their mistakes, but real sharp ones learn from mistakes of others. When we start our learning journey, we start from the bottom, from the unconscious incompetence. And then hopefully with time, we climb the pyramids to reach the unconscious competence, where you're in this flow state, you're doing everything, but you don't have to think about it. It's like trying to learn how to drive. In the beginning, you need to think of every movement you do, but with time, that gets better. I think also you need to be aware of this Dunning-Kruger effect. I've been there. Your confidence level, especially in the beginning, is inversely related to your knowledge. I've been there a lot when I was a senior. Sometimes when I'm back from a conference, I saw very complex cases. It's easy. I can do this. And it's not. And then you start going back, okay, it's more difficult than it seems to be. I need to work harder. I need to understand where my limits are, what's my skill set. And for being a good surgeon, it's not only the psychomotor skills, or it's not only your dexterity or synchronization. You need to have the cognitive skills and the mindset skills, the decision thinking, the decision making, the problem solving, and also the performance, the peak performance status, where you have this flow and focus and awareness of what's surrounding, and just don't be distracted with what's happening. And we have to admit, the surgical training is not easy. It's challenging. We get out of our comfort zone and get through these stages of the fear where we're vulnerable, we're affected by others' opinion. We don't have a lot of self-confidence. And hopefully we move to the next stages, the learning zone. We start acquiring our new skills and get more comfortable. And then the ideal place to be is in the growth zone. As they say, if it doesn't change you, if it doesn't challenge you, it won't change you. One of the questions I had when we were like junior residents, or okay, can I be a good surgeon? Or what are the qualities that I need to be a good surgeon? So this paper was published in the International Journal of Surgery, and it was asking a simple question: are surgical experts born or made? And so they tried to understand how important are the innate abilities in the development of surgical expertise. And given appropriate training, can anyone with determination, hard work, and practice can turn a normal individual to a surgical expert? I'm going to quote the part of their conclusion is they concluded that the innate talent plays an important role, but it's insufficient on its own to produce a surgical expert. Psychomotor and non-technical skills are necessary for the progression in the current climate of in the light of our training curriculum. And they concluded that the literature suggests that surgical expertise is reached through practice, and surgical experts are made and not born. And this is actually what I have seen from like myself, my co-residents. Like it's probably the best surgeons are those who like, paid attention to the details, worked hard, and I think these are turned out to be the better surgeons. And this is also another paper from JAMA Surgery, where a panel of surgical educators, they put a list for 21 characters to evaluate the performance of their graduating general surgery resident. And 50 faculty from a 14 residency program evaluated around 300 graduating residents. And the interesting thing is, like when they did their analysis, the top factor that they found that probably is associated with a better performance of these graduating surgeon was surgical judgment. And I'm gonna read here from my notes like how they define the surgical judgment. So like someone with excellent surgical judgment is consistently and accurately able to determine when a patient shouldn't undergo an operation. They also consistently determine the urgency of surgical interventions when necessary and can decide which operation is more appropriate. They are consistently display exceptional intraoperative decision making. And technical skills came as the sixth factor in the performance of the graduating surgical resident. And when they did a regression analysis, they found that like without taking into account other factors, surgical judgment, leadership, and medical knowledge are the most associated factors with a better performing residents. I think there's a lot of similarity between sports and surgery. So like Michael Jordan, which I think probably is the greatest athlete of all time, it's like my best skill that I was coachable. I was sponge and aggressive to learn. One other thing I think we all experience is like the imposter syndrome, like feeling that we are not good enough or we are inadequate. This is like a nice editorial from the Journal of Cataract and Refractive Surgery about a solo practitioner in New Zealand who just described his experience with imposter syndrome and cataract surgery. And I'll be a little bit focused more today about cataract surgery because this is what most of us do and most of what you're gonna do after residency. And he said, like, even with the good results he was having with his patient, he thinks that's just luck. And that actually put him more under pressure for the future. And he said, like, self-doubt is something all cataract surgeons have from time to time. It drives our desire for better patient care, audit, and lifelong improvement. One aspiring surgeon said, I'd like to meet someone who hasn't experienced imposter syndrome. I think we all had it. Since there's no study that evaluated the prevalence of imposter syndrome, I found one that evaluated and looked into young neurosurgeons and residents, and they found that a total number when they asked young neurosurgeons and young neurosurgeons was like less than 40 years age. It was probably residents 7 years. The imposter phenomenon or imposter syndrome was present in around 85% of these residents and neurosurgeons, and they found like females like having a PhD or higher level of education and pursuing an academic career was actually predictive factors for having imposter syndrome. That's a nice quiz. Like anyone can help me answer that quiz. Let's try to count how many times players wearing white basketball. It's a famous psychological experiment. Anyone? Okay, how many passes do you guys count?
A lot.
That was just 16.
15. The other thing is how many of you, let's see the graph. It's like when they did this experiment, like 50% of the people they didn't notice the gorilla. That's and then the Simon's the psychologist who did this experiment, like it's the famous book called The Invisible Gorilla Syndrome or the Selective Attention Phenomenon. I experienced like intentional blindness a lot at this thing. Like and they define it as failure to notice fully visible but unexpected objects when focusing attention on a task. For example, radiologists like send the patients like possible optic neuritis. You do an MRI, like an incidental mass lesion that was ignored. And they that's the I would say the bias of did I answer the question I was asked correctly, or was there any other important questions that was missed during my exam or during my evaluation? Many times, like I get a referral for a glaucoma suspect patient, like when I dilate them, they have retinal tears. A couple weeks ago, like a patient, actually she was sent from a retina specialist. She had a breast cancer. When I dilated there, she has a choroidal mass. Just you need to be systematic because like if you don't have an outline or a system to follow, you'll miss a lot of things. One of the things just when you're surgeon in training is like your attitude or like your mentality. And like I don't remember where I read this, but like your mentors are not your friends. Your friends, they can tell you what you need to hear, what you want to hear actually, but your mentors will tell you what you need to hear. They will tell you the truth, and you need to accept it. And one of the simple things, like just basics, just when you're in the ward, try to show up in time, try to show up prepared. Like read about the cases, you know what procedure you're doing. Because like when I was a junior, I did this mistake. Sometimes I just show up with OR, I didn't know what we were doing. I'm just here, teach me. It doesn't always work. And also, like when you're given a feedback, try to work on that feedback. Ask question, okay, how can I improve? How can I improve in this? And one important thing is at this stage, you're building surgical habits. It's easier now to work on building correct surgical habits rather than trying to correct them many years down the line. It's more difficult. I had bad surgical habits at some point, and just trying to correct them, it takes a lot of effort. And sometimes even when you're doing like what we were talking about, like building good surgical habits, if you're doing routine cases, you should be fine if you did your steps like 70% okay, 80% okay. But if you're doing more complex cases, your margin of error is too small. You need to do every step almost perfect. And that's the a graph actually from Character Coach where he's talking about the mentality of people who drop out from surgeon. When they are a junior surgeon, they just drop out. They can't pass the frustration barrier. And then the competent surgeon with time just pass the frustration barrier, but they don't push themselves a little bit more to pass the passion barrier to be an expert and master of surgeon with time and reach this flow state we're talking about, which is doing everything comfortably, unconsciously. Michael Jordan again. You don't show up on an OR day, expect to be great. Greatness happens in practice. Like I had one attending before, always tell us we just practice in the wet lab and we apply in the OR. There's no chance that you're just start to learn everything from the scratch of the eye model. You can practice as long as you want. And everything starts with the basics. So that's a nice book. It's called Reflections of a Pupil. Probably, maybe most of you have read it before. But one of the nice chapters I like there is like it's called "Don't Fight Yourself." I'm gonna quote what they said. Like surgery can be described as a pyramid, with each step dependent on the one before. How successful you are with one step influences how challenging the next step will be. Everything from draping properly to at the beginning of the case to taking the speculum out at the end requires care and vigilance. Do yourself a favor and make sure you always address the basics. Get a good night's sleep, eat something before your day, and take time to adjust the stretcher, patient's head, pedals, chairs, and microscope. I struggled with this my ergonomics for some time because like when I started, like, how I did my residency, I didn't do my residency. I used to grade superiorly. It's like transitioning temporally took me some time. Like my knees are hitting the bed. I can't sit. I'm not comfortable. It took me some time to adjust. And performing surgery, especially when you are in the early stages of your training, can be very stressful. So the last thing you want to do is make things harder on yourself than they need to be. We're talking about ergonomics, and like one of the misconceptions that I had was it's okay, just it's 20, 30 minutes, I'll say whatever, I'll just push through and I'll be fine. But the problem, if you're not sitting correctly, you're not comfortable, you don't operate well, your hands are not in neutral position, you don't see well, it doesn't make sense. And like for your health, like it's 30 minutes or 20 minutes when you're learning, but like multiply by how many times? By 30, 40 years. That's detrimental to like your spine, your back. I had this picture especially for neck because we talked about this last year. I don't know if you see, yeah, these are the extenders or the dice has for the microscope. Like neck, you can tilt the microscope, you'll be fine. And that's also another pictures of bad posture, bad ergonomics when sitting here. One of the nicest books that has chapter in ergonomics is this illustrated Advanced Anterior Segment by Mohamed. Just like 10, 15 pages, a lot of nice diagrams. So here they're describing how you can sit correctly. So you need to lower your seat height. And so if your seat height is low and your pedals is a little bit away from you, then you have a little bit of flexion in your knees. And this way you are stable and you're not leaning forward. You're not falling over when you have a high stool. It also allow for more room between your knees and the bed. The same thing is like if your seat is low, it allow more better control. And like your elbows should be slightly below the patient's eye level, so your hands are more neutral position. Because one of the problems I always used to do, like if I'm in a higher position, I'm just pushing the eye away from me. So you need your hand to be a little bit flatter, and the only way is just to put your shoulders down. And your shoulders should be in more neutral position, like beside you, relaxed. And because that with time, your surgery probably is long. You'll after some time will start having tremors, start doing vigorous movement. And one thing also I learned is sometimes if the patient is a little bit overweight or like they have high shoulders, you can either tilt you move a little bit superiorly, or you can actually move the feet of the bed slightly away from you. So you're turning the patient. Just try to sit comfortable. Also, how you adjust your foot pedals, that's more ergonomically better and easier and natural position is you have your foot pedals slightly away from you, directed outward. Because if they are internally rotated or directed inward, like you're not in a neutral position and can affect your hip on the long term. One of the things that like I was told, like when I was first couple of times in the war, just to watch, we like there wasn't a lot of double camera videos then, just to watch how the expert surgeon or like the more senior surgeon, how they hold their instruments, how they move outside the eye. So that's nothing. I don't need to learn this. That's natural. And first time I tried to do an eye, that was terrible. So you need to learn how to adjust your instruments, how to hold the instruments, where your probe should be if you're trying to crack, if you are trying to do chopping. That's very important. I think I like Cristiano Ronaldo. I think one of the best soccer player ever. One of the technical advantages that he has, he can use both his right and left foot almost equally. We as a surgeon, an ophthalmic surgeon, it's a bimanual surgery. However, the problem is like we don't know how to use our non-dominant hand. And it starts with like simple things. Just start forming like normal daily routine. Just brush your teeth with your non-dominant hand. Put makeup if needed. Do some hobbies, like if you're doing coloring or anything with your non-dominant hand. Use the computer mouse when you are in the war with your non-dominant hand. Actually, the last two things I did last year, second half of my fellowship, just do all the modules of the surgical simulator with your left hand and practice suturing. Go into the wet lab instead of holding the needle holder with your right hand, move it to your left hand. And I think it helped me.
I think went to
Sure.
buy 2 dogs. We got 2 dogs. You have to do this all the time.
And
It works for the spouse too.
and the devil is in the details. Like initially when I was like, I'm just doing a side port. Many times I had a large side port because when I was taking my plate out, I just enlarged my side port. Common mistake. Sometimes I put my side port very close to my main one. Just I can't crack. Like like it makes the whole surgery difficult. When I try to do any cracking, I just distort the cornea. I lose the EC. So like it's important. It's not just a side port. You need to learn how to do it correctly. I remember one of our junior residents actually, instead of having his parablade or side port blade flat with the globe, he had it tilted. So like every time he was trying to get in and out with an instrument because of Decimate detachment, when he's trying to get with the IA, we had a huge Decimate detachment. It needs one wrong movement or decision to make the case more difficult or complicated. I did this actually this week. Had a lady, was like a bad NF1, a lot of neurofibromatosis in her eyelids. Neck was fused, so she can't extend it, and it's fused to the right. And very shallow AC, significant cataract. So okay, hopefully she will not show up, but she showed up for the one. I tried to do everything correctly, so I just blocked her. I know, like with the positioning, I will not had a good read reflex, so I stained, although the character wasn't terrible. Put a ring, did everything correctly. Did a divide and conquer because like her AC was too shallow, so I don't want to do any phaco in the AC. Done with my IA. Did she also had an angle closure glaucoma? Says, should I do goniotomy? So I was debating. So I implanted the lens when I was like my scrub tech was, are we proceeding with the goniotomy? I said, yeah, we'll do it. When I was just dialing the lens, I did something wrong. Like I didn't have a lot of OVD, so the AC was a little bit shallow. I dialed the lens. I was at dialysis like 3 to 4 clock hours. The interesting thing is one of my attendings when I was a resident, he told me never do this. I didn't do it. After the surgery, I called him. You know what? You're right. I know why you told me to not to do. Why? And so I ended up putting a CTR, the anterior vitrectomy, because there was a lot of vitreous prolapse. But I made a very difficult case more complex because I lost my attention for 10 seconds and I did a wrong decision. I should have been safe. I should have irrigation inside the eye or just put the haptic and then dial it when it's in the bag. I should have dialed the lens this way. I saved the case, but it wasn't fun. Anyone before opened the capsule when he was injecting with Triban? I did it before. At a flat AC, my attending told me actually the previous case, don't get into the AC on when the AC is too shallow. Didn't listen, injected, had a longitudinal tear in the anterior capsule. So I learned the lesson. I had a case a couple weeks ago, and I had one of the residents, like I had a flat AC, so I injected PSS before. And I was asked, why are you injecting PSS before the Vision Blue? Because I learned this the hard way. So I don't get into the AC when it's too flat. And one thing also, like I think I did mistake in the case that goes to dialysis, and I thought I'm done. I just implanted the lens. And actually the case is not done until you remove the drapes. Here's some examples. We're done. We're hydrating. Everything's going well. Case looks good. Yeah, we can call it a day. Just hydrating the sideboard. Did you guys see what happened? That's a huge desymate detachment. Show the video, guys. So like there was a huge desymate, like half the cornea. It's you think you're done, but you're not. Another case, we're done. Just hydrating the main wound. Shoot. And actually in this case, the posterior capsule was open. Another one. We're not done. I think also Michael Phelps was one of the greatest athletes of our time. And he talked a lot about visualization and mental preparation, how you need to plan for your like race or that's what I always think it's suitable to do, especially when you're trying to learn, is just when you're in the clinic, when you're planning for surgery, even if it's relatively routine surgery early on, try to visualize what you need to do and do a mental run through what do you need. So like having my smart phrase, like a few things that I need to remember for every case. Do I need to use a ring? How's their dilation? Sometimes I just get a little bit more because I have a little bit of OCD. I just decide what nuclear fracture technique I will do. So like for this case, for example, was soft. So I'm gonna tilt and chop. Put some notes to remind myself. I was like, that's a myope patient. So I need to, okay, I'm gonna do a smaller axis. I'll do a shorter tongue. And that's an E2F case. So I need to make sure that my rexus is perfect and good size and centered. One other thing that I think I didn't do early on, and I think it would have helped me a little bit, is just try to record every single case. I learned a lot from going through these cases and just trying to break them down. Okay, what did I do here? Did I do it correctly? Is like when you try to get more efficient, like how can you shorten this time? Surgical time, we were always crazy about like, okay, I did phaco in like 10 minutes. Like then my core residence, oh, I did it in 7 minutes. You just need to be efficient and not rushed. Just do whatever needed to do, be efficient, no unnecessary movement, no wasted time. And one thing, sometimes you can control some of the variables, not all of them. For example, this is a screenshot from a catech coach also. And when they were talking about the cycle time for cases in the VA was 60 minutes, and they shortened it to almost 40 minutes. By shortening the surgical time didn't change. Surgical time for the residents was like 18 minutes for the case, and the turnover for the pre-op the same, was 14 minutes. But instead of wasting 10 minutes for setting up the room, setting the microscope, you just shorten this for the draping microscope also. Do it quickly, have everything ready, multitask. Same thing for after you're done, just remove the drapes, put the shield. You can ask the nurse to do it, or you can have everything ready, just put it and keep moving. That's a way to shorten your surgical time, but not being rushed. And as I said, watching a video are very helpful in trying to understand what steps you take a lot of time to. And one of the things that I learned is like if I do things correctly, the surgical time is less. If you do every step correctly, you have to struggle less. You make every step that's following easier. And when you're starting either in your residency or when you start practicing, when you're preparing for your first cases, just do proper patient selection. Don't make things harder on yourself. For example, just try to block your first few cases when you're in residency. Some people, even like very famous people in glaucoma, they have traction switchers in their mix when you see their videos. We had a case conference, I think a week ago. One of our residents, she's a great surgeon. She was trying to learn stop and chop, and just so she chose a +4 case to start with, and that was like her first or second case. Simply didn't crack. She's trying to pull a half out of the bag. She opened the bag. So that's not a right choice to do. And like when you're doing your first cases or like you're in a new place, just make sure that you have everything ready. Many times I ask for things and I figured out like my scrub text, she doesn't know what I'm talking about. And have a plan B. And here, for example, like this is something I always tell the residents, like if you are on yourself or like on your own, you're doing your first few cases, you're doing your first few mixed cases, choose a myopic patient. If your TM is not pigmented, use a tri-band blue. It helps visualize and stain the trabecular meshwork. One of the things that I struggled with a little bit when I was starting is like I was pressing with my gonio lens. So you use hands-free gonio lens or stick-on lenses. So you don't you press less on the eye. Like here we can see here this video, just the TM is very clear and very nicely visible. And also do uncommonly performed steps in routine cases. Try to inject OVD with your non-dominant hand. First time, like in first 10 cases or something, as any great surgeon, emulsifying out of the safe 5mm zone. Oh, I think we have a PC tear. Then, okay, you need to, my attending told me, like, you need to inject OVD with your left hand. You can imagine. Trying to, like, for 20 seconds, getting into my side port. I can't. Now I'm in the side port. I want to inject. I don't know how to inject with my left hand. Stay where you are. Inject it with it. So like if you are familiar, if you trained yourself to do this step, when you are faced with the situation, there's already a lot of stress. So you don't have to do it for the first time. Try to load and inject a 3-piece, even in a routine case or simple cases, because we don't do this a lot. So like if you are faced with like a case where you have a PCTR or you need to inject a 3-piece and you're not very familiar with the stress, probably you want to be able to do it correctly. Also like practice how to do to enlarge your smaller rexus if you can. Sometimes you need to stop. Sometimes perfect is the enemy of good. That's also a video of cataract coach who has this posterior plaque after he's done with the cortex removal. And he's a very fast surgeon, actually. Like you can see some cases are like full cases in 6 or 7 minutes. I don't want to waste your time, but he has been trying to remove this plaque for 2 minutes. Like, and then he stopped, planted the lens. I'll do yak. That's very reasonable. A little bit of quizzes, because like what a lot of what we're doing on the surgery is based on observation and pattern recognition. So who wants to take the first one? Maybe anyone? Do you want to take it?
Sure. You want me to just
Yeah, tell me what do you see here?
like like start the maybe some zonular laxity there.
Correct.
Um,
Yeah, that's it. Like there was zonal laxity. Yeah, if you missed it during your case, you did vigorous hydrodissection, a little bit of vigorous rotation, you lost the back. Sam, do you want to do this?
Sure.
What do you need to do?
Stop.
Correct. So whoever was doing this phaco, he didn't notice it. He kept doing it. Like we ended up with a huge corneal curve. On the other side, this resident was a little bit smarter as Sam. He stopped, cleared the phaco tip, went in again. He saved the case. Okay. Ryan, maybe?
Sure.
Okay, if you're doing phaco and you see this, what do you think? What will you do? Probably, that's true. So probably punched out, so inject OVD, make sure that the PC is posterior capsules are intact. Who wants to do this? Kevin? Capsular block, snap sign. Capsular block. So he was pressing on the nucleus, injecting PSS vigorously, opened the posterior capsule. There was no way for the PSS to get out of the back. And we'll keep the video. And he didn't notice it. Keeps pressing.
So what did this, or what would you do knowing you had the bag or the whole lens in there and the posterior capsule?
I would try to convert it to extra.
So would you do M6 or would you just enlarge your
So
cornea?
it depends on your comfort level. I'm not very comfortable doing M6, so I just enlarge my cornea wound. So here the nucleus is dropped. One of the things, just maybe like later on when you start getting better, just try to follow up your patients to see like how you're doing, how to modify your techniques. Like sometimes you're getting a lot of corneal edema next day. Need to modify my technique. I'm like doing phaco very anterior. And one other thing is after graduating, maybe if you will know your skill set, you know your limits. If there's something you're not comfortable doing, just refer it. One of the things also like I learned recently, sometimes your perspectives are not the same as your patients. Pain control and anesthesia is very important. Had a lady first or second week when I started at Louisville. She had a very bad uveitic glaucoma. She's like 50-year-old. She needed an urgent tube. I said, hey, well, we usually block you. We do it under MAC. Yeah, that's fine. Like after we started, she's anxious. She's moving. Are you in pain? No. Give her more block. She's like very unhappy, very uncomfortable. Surgery was textbook. That was great surgery. Like next day, she was like very upset. I was in a lot of distress. I was in a lot of pain. But with time, we became friends. I'm doing her other eye next week, but under general anesthesia this time. Sometimes also the refractive outcomes of your patients. I had some myopic patients. Like leave them maybe a little bit myopic, maybe half, maybe minus 0.25, and they hated. So okay, I told him, okay, you will lose your ability to hear, but like sometimes, oh, I can't put my makeup in the mirror now. So you need to understand what their perspectives are, what they're looking for. And as I said, like take every piece of feedback and always ask for honest feedback. You don't want false reassurance. If there's a problem, you need to, okay, no, that have a problem, how to address it. Peer mentorship, I think it's important. Talking with your classmates, your friends who are in other programs, even after practice. I think by talking to friends who are like in other places, other countries, that I got new ideas and new things to learn. If you have time, you can start. You have like a couple of days off, a week off. Just go shadow someone or his clinic. You don't have to travel. Just do it in town. Keep reading. That's my last slide. I will conclude also with a quote from the Reflections of a Pupil. You know what? Who has the hardest job? The guy coming off the bench to replace the injured quarterback. He's not warmed up. He hasn't had any reps during a game that mattered a month. And yet, if he's good, he's ready. He says, "Put me in, coach." Being a surgeon in training is sort of like being a backup quarterback. You never know when you're going to have the chance to jump in and play. Message received. You can succeed if you only know half of the playbook. Just like the quarterback coming off the bench, you have got to be prepared for every opportunity. Hopefully you guys don't stay on the bench for too long, and once you're in the court, you can do well. These are the questions I sent before, and now that's what I have for today. Any comments? Okay.
That was great.
Thank you so much.
We don't talk enough about like, we talk a lot about surgery, but not about how to like the mindset of surgery. Can you talk about, we often think of like a complication of the PC rupture or something like that and how to face that. But you mentioned some, errors or missteps or technical challenges that happen early on in the case.
Correct.
Can you talk about what you do, when you notice like that paracentesis isn't great, or, the capsule was broken with the trypan. Like, how do you get yourself in the right mindset to sit back down and say, okay, I slept through 90%?
I'm stuck here with the patient. I need to finish this correctly.
We were at AUPO and like somebody talked about when they have something like that happen, they get up, they
Right,
lift the microscope, they walk around the room and they sit back down like
Yep.
they're like restarting the case. So,
Inject OVD.
and always inject.
Any other questions? Any comments? Any comments from the attendings? Because I just have been in practice for 4 months. I don't have a lot of experience.
Mohamed, this was a great talk. I really think this is so much more important than learning the technical skills of surgery. Just setting yourself up, your mindset about who you choose, what you do, how you prepare, I think is 90% of your surgeries. So thank you for doing this.
No, thanks so much, Dr.
Good
Cooper.
to see you again.
Thank you, Dr. Cooper.
I was just gonna say, I think it was a comment that I heard it from, so of course it's from Kod. But when a complication happens, he says you break it down into steps.
Correct.
It's not, I just broke the capsule, how am I going to be done with the surgery? It's what do I need to do? Like anything in life, if there's a huge obstacle from you to like look at small measurements and think through it too. So that also helps prepare your mindset. So if you do reach a complication, especially early on in the case, instead of worrying about it and the next patient, just get to the next step.
And I think like always like when someone like one of those, oh, I broke a bag. Question is like why? Like you need to learn what was sometimes the anatomy is that there's something in the anatomy that's not correct. Or like why did you do? Why this happened? I think that's more important to learn from every case and hopefully avoid making the same mistake again. Any questions?
Another comment would be, pay attention to what you do, the day or two before your surgery day, if you have a big surgery day. I've been burned a couple times by water skiing. Getting under the scope, like, why are my hands shaking today? I mean, there really is, there's a lot of subtle things throughout your lifestyle that can contribute to your surgical skills. So you set the big picture about all of that.